Hello and welcome to our webinar. We're starting nice and promptly at 3 o'clock. So for those of you that don't know me, my name is Rebecca Fisher. I'm Allied Health Professions Prescribing Advisor at NHS London Procurement Partnership. And I also work part-time clinically in paediatric eating disorders based at the Royal Free. And on the call with me, I have Sinead Burke. Sinead, do you want to say hello?
Hello. Sorry.
And Sinead is our AHP Information Officer at Royal Free London NHS Trust. We will be going from 3 till 4 today, and we are, of course, talking about nutrition transfers of care, a recommended digital data set for London. Next slide, please. So a very warm welcome, as I've said. On the webinar today, we've got a really excellent panel with us. These include people that have been on the project from the get-go, but we've also got Steve Tolan, who is our Chief Deputy, let me get the title right, Chief Deputy Allied Health Professions Officer for NHS England. And I wondered if you'd like to kick us off today, Steve, by giving us just a few words to set the scene.
Hi, thank you all. So I work for NHS England nationally. I'm a physiotherapist by background, so by no means the expert in the room on this topic. But what we do know is there are challenges around borderline substances. There's challenges around transfer of care in relation to nutrition. And so the reason why I'm here actually is mostly to listen, but in actual fact, to really endorse some of the approaches, just trying to think about ways in which we can improve that transition. NHS England is currently running a red tape challenge, and that is very much focusing on how we can be more seamless, avoid waste, and make better decisions on the transfer between secondary and primary and community care. And so really what I'm interested in, and I hope you'll all get to hear alongside me today, is how this is a potential solution for this particular topic in this area that could be a benefit to service users in the longer term. So I'm looking forward to the event, looking forward to hearing it, and hope you are all too.
Excellent, thanks, Steve. So I'm going to introduce the panel fully later on. But just to acknowledge before we sort of move on that we've got quite a mixed audience today. I know some of you have been great enthusiasts on the project from the very get-go, and some of you will be quite new to this work. So we're aiming to make sure we're catering to all the different audiences. So it'll either be a refresher for some of you or an introduction for some of you. Just a couple of housekeeping points. You're all automatically on mute unless you're a presenter. We are recording today's session, and it will become available after the event. We will share that along with the slides in due course. We've got the chat disabled, but if you've got any questions as we go along, if you please pop them in the Q&A, that would be great. And then when we get to our panel section at the end, either myself or Sinead will answer it, or it might be one of the other panelists is best placed to answer it there and then. So I think that's all the housekeeping points that I wanted to go through. And finally, the recommendations, the full recommended digital data set are available. They are on the link there, or you can use the QR code, and I think we can also pop them in the Q&A, just in case you'd like a little look, so that you can see the recommendations in full. We won't have expected people to have read them. We managed to get them onto the website a week or two ago. So we're not expecting people to have read them in full, and we won't try and read them all out during the course of an hour's webinar, but this is just the opportunity to sort of say that's to go away and sort of take up in your own time. So next slide, please. So what are we trying to cover off today? Well, first and foremost, we'd really like to go through the why, what, where and when of this project, and why are we all here today. We're going to begin to explore how the project can be implemented, but that's going to be a sort of briefer version with more thoughts on implementation to come. We are going to talk a bit about measurement because that's really important to making a change. And then lastly, we're going to ask our panel to help us reflect on the journey so far, challenges, concerns, and celebrating the sort of journey that we've been on and what we've achieved to date, which I think is this publishing of the recommendations. So handing over to Sinead now, I think.
Indeed. Thanks, Rebecca. So hi, everyone. Obviously, we should start by talking about why we've produced and published this guidance. And effectively, what started as local conversations within North Central London sparked interest in people understanding if other regions felt the same way about the process of transferring people under the care of dietetic services across care settings. So one of our dietetic colleagues who's on the panel today, Jane Cunningham, carried out a survey. I think we had about 25 responses across London, and immediately some themes emerged around poor user experience, and that is at both ends, the referring and receiving end of the process. And this was largely around the fact that most of the time, patient transfers of care now for nutrition are done by what is a largely manual process. So often it's copying data from patient records over onto a Word document or something similar. And this is in spite of the fact that most London organisations, most London trusts have adopted some form of electronic records in recent years. The other thing is that there is quite a variation in referral processes across organisations. And, you know, if you imagine one acute service may need to refer to a number of organisations, and one receiving organisation, so it typically tends to be sort of a community team, will be receiving patients from a number of centres. And standardising was sort of a strong theme in the response when people describe their experience of transfers of care, the need for standardisation. And look, the opportunity is here. As Steve said, this is a potential approach for us to achieve that. And using digital as an enabler of that really helps to reflect, really does reflect the wider ambitions of the NHS, which is to, where it's really positioning itself to say that the role of digital transformation is to drive efficiencies in delivering patient care. Standardisation can also be applied when we think about clinical documentation. And back in 2019, Suzanne Rastrick, via the Digital Framework for AHPs, encouraged us to take up the sort of the challenge of improving how we adopt some of the nationally mandated standards like clinical language. So I've got here their SNOMED CT. Some of you are really familiar with this, and some will be less familiar with the impact of using sort of structured and coded terms and diagnoses and findings in terms of how you can then analyse outcomes within individual patients, but also on a service level. And then finally, although this project is first and foremost interested in, you know, improving efficiencies and quality through digital transformation, a concept that arose really early in the stakeholder conversations was this idea about us as a sort of dietetic profession committing to really providing that evidence basis for ONS prescribing, or certainly when we're making requests, so that the right people are prescribed the right dose of ONS and for the right duration. And what we've reflected is that although it's not the primary goal of the project, actually this work has a real role to play in reinforcing how digitally enabled record keeping and transfers could make it clearer to other teams where we have met the evidence threshold for recommending ONS. And as Steve said already, sort of borderline substances, it's a hot topic, and we will continue to be monitoring the landscape there and how that might impact how we reflect that in our transfer documents. So the clinical and digital principles that underpin this work are important to acknowledge. So if we think about, first of all, the concept of records, electronic records, they're being certain parts of a record, certain pieces of data, acting as a source of truth. So different parts of a patient record are generally thought of as the best place to hold a source of truth for a certain piece of information. And look, we do expand a lot upon this in our published documents. But just to give you an example, let's say a diagnosis or a finding, something like protein energy malnutrition or cachexia, IBS or class 3 obesity. These kind of diagnoses should always be captured in a structured field that's been configured to associate that sort of SNOMED terminology, that diagnosis, with a code in the background. And we won't need to go into the detail of how that happens here, but just understanding that where you put data, rather than, let's say, putting a diagnosis into a bit of free text that's floating in a dietetic note or letter, has a really big impact on managing and sort of monitoring patients. Using some of those standards also moves us towards better automation and interoperability. So, for example, if a community or acute organisation captures their data in structured or coded terms where appropriate in a patient record, technical solutions can then be in place to transfer those pieces of information into a receiving centre, such as a primary care, a GP practice, where the sort of foundation IT build has been set up to receive that type of data via, transport system into this type of, receiving field. And this is that idea of pushing pieces of data, or let's say, for example, a clinical document, straight from one system into another. Now, that is only in sort of trial basis at the moment. I think actually CLCH or CNWL is actually undertaking a trial of this principle already, pushing some of the discharge summaries from one system into the other. But these are the kinds of things that really, if we're not sort of keeping pace with the kinds of developments that will allow us to do that, we'll get sort of left behind as dietitians. But another really important thing is around the visibility of that documentation. I think this is really important for us as dietitians. If you create a document within a clinical system, like an EPR, that document can then be catalogued in such a way, labelled or sort of cohorted as being a piece of clinical correspondence to be displayed into something like a patient portal or health information exchange, for example, which, in London we refer to that as our One London system. So, and, visibility of documentation for patients and care providers is a really big one. When you are creating a letter or a transfer document outside of the patient record, like on a Word template, for example, and then re-uploading it into your patient system, not only are you double handling a lot of data, but those of you who are familiar with this process will know that you also then run the risk of not being able to appropriately sort of label or categorize that uploaded document as a piece of clinical correspondence, and therefore it isn't got that visibility that, say, another letter might have, like an inpatient discharge summary or an outpatient clinic letter. So this is the other reason that we're really promoting this idea of creating a letter from the patient record, driving the production of that letter from there. And then finally, when it comes to prescribing, we've been really mindful of the work of Alison Smith and the ACBS, where evidence-based recommendations for prescribing really should be followed when we're transferring patients. Let's say we're asking a GP to prescribe, or notifying the community team that we've made that request from primary care and wanting them to support us in following up. And any steps that we put into the transfer of care process that can help us to make that a little easier will be really important, and not just easier, but make it clearer, sort of thinking about the quality of how that information is transferred. Some of you will be aware that some parts of the country have already begun taking a stance that oral nutrition supplements will be, if they're prescribed in an acute setting, that they will be discontinued and only continued in primary care where that evidence criteria has been met. So, for example, a dietitian has written a letter where they have then outlined what that threshold for prescribing or recommending a prescription of ONS is, and demonstrating that they have evidenced that in their documentation. Look, and really mindful that this type of decision, like shall we take this approach in our organisation or within our ICS, that's not really within the gift or the purview of this particular work, but we wanted to highlight it because we think it's got a real potential that if we can improve our transfer of care documents produced by dietitians and make it really transparent where we've met the threshold of evidence for prescribing or recommending an ONS prescription, it makes it a lot easier for prescribing colleagues in primary care to identify those patients that are suitable to continue on and those that aren't. And the next thing I want to just talk about before I hand you back to Rebecca is the project aims. Now, I'm not going to read through all of these. They are outlined in our project document, of course, in our published document. But broadly, we're already started to hear this and understand that this project has been around how we impact quality and efficiency of that nutrition care process. And we want to be able to do that by being mindful of the standards that already exist for us in terms of transfers of care and also some of the clinical standards for transferring patients. We know that unwarranted variation, the DIRFT program, or Getting It Right First Time, has played a really large part in bringing that concept of reducing unwarranted variation to the forefront. We heard from many people during the stakeholder process that this was a really important way that we might show the success of a project. We are mindful that we can't, and we'll talk a little bit about scope. Rebecca will talk about scope briefly. We're mindful that we can't necessarily take into account differences in commissioning decisions. So, for example, who might be able to be seen by one particular service versus another. But certainly, when you're sending, transfers of care to receiving organisations, they should be able to expect that they are working with the same data set so that they can make clinical triaging decisions on the basis of having similar information available to them in that transfer of care document. And like I've mentioned already, the last thing is that we want to make sure that we are really improving how, making it easier to evidence that criteria threshold for ONS so that we can have good decision making in primary care. So I think I'm turning back, to Rebecca now, who's going to talk us through a little bit about what the process has been up until now.
Absolutely. So it did all start with a lot of local discussions, and then a survey kindly done by Jane Cunningham from Barnet Hospital, which was circulated by London dietetic managers. And what I think that really showed us is that no matter your viewpoint, is that the process was quite frustrating for many people. And so there was quite a lot of enthusiasm. So after some work on defining scope, and Sinead doing some excellent work to collate all the different existing Word documents and processes, and we started holding some stakeholder meetings to review. And it was fantastic, the really warm reception this got and the good attendance. So that was really encouraging for us, and I think gives our work real validity. So we then, as a steering group, we then reviewed all the discussions. We did a further consultation phase just to sort of update on how it had all come together. We then reviewed those results. We only asked for one response per department to sort of really bring the project to a sort of natural conclusion. So we did this review, and then we published the work, and now we're at the phase of sharing our work and really talking through about how it can be implemented or what we've done to date. So yes, next up is the scope. So obviously we're saying transfer of care, referral from secondary or tertiary dietetic services to community dietetic services. recommendations to GPs for the provision of ONS, recommendations to GPs for the monitoring of people diagnosed with malnutrition who will not be under the care of community dietetic services, and then transferring of care from community dietetic services to GPs. There are some important exceptions to the scope, including home enteral feed discharges and registration paperwork. And indeed, that might come in a later phase. That would be an interesting future iteration, but it's not in scope for the time being. Also, interoperability of platforms to allow viewing of transfers of care. This is bigger than us as a dietetic profession or a group of people collaborating to sort of improve nutrition transfers of care. Also beyond scope, as Sinead has just mentioned, is the commissioning and variability in criteria for community dietetic services. We know this is a big source of frustration for many of us. It can be really, really challenging. And we know that many ICSs are beginning to do a lot of work to standardise across the ICS what the different community provisions will be. But that is beyond scope. And then last but no means least, discharge of people on ONS to primary care from hospital when the patient is not under the care of a dietitian. So we know a lot of the time that ONS end up on discharge summaries without dietetic involvement, and no one's very sure why the patient is on ONS in community when they come to be sort of picked up in primary care. And there will be decisions to be made about how that's handled within each ICS. Next slide, please. So just to really sort of reiterate, and I think we've already been through this bit on stakeholders, that we've had people actively involved, whether it's dietitians and dietetic assistants contributing, primary care staff, ICB staff, the group that I support, the LPP Nutrition Group, London Dietetic Regional Managers and the London Medicines and Pathway Group. We've also involved the British Dietetic Association digital team, the BDA Optimising Nutrition Prescribing Group and the Older People Specialist Group. And Sinead has very kindly liaised with the PRSB as well. So we have taken it across everywhere. So what are our outcomes?
Sorry, I got a little trigger happy with the slides there. The PRSB, by the way, I should have defined that. It's in the published documents, but it's the Professional Record Standards Body who help to support the sort of transparency of a lot of the guidelines that we refer to both in this presentation, but also in the published documents. So the outputs of this task and finish group, as we've said already at the beginning, have been published on the NHS LPP website. And look, following recommendations, a lot of suggestions during the consultation period, what we did was we divided up the work into separate documents. So we have a transfer of care, I suppose a rationale document, sort of a guidance for how to consider the recommendations. We then have the recommended digital set separately and a couple of transfer of care sample documents. Now, if you have seen it, what you'll realise is that the recommended data set itself speaks to not just what the data pieces are, but gives a bit of a steer on how you might digitise or, sort of automate where appropriate a particular piece of data into a transfer of care. And there's a natural balance always with any kind of clinical documentation to be struck between structured and unstructured data. And a lot of that has actually got a national steer on it already. The guidelines that we've referred to, like the Transfer of Care Initiative and other guidance, gives us a bit of a steer as to what documentation should be captured in a structured way, in a coded way, what can be entered in free text. And so really as you might imagine, it's not been in our interest to sort of digress from a lot of those recommendations. When it comes to the sample documentation, and like we said, we're not expecting that people will have had a lot of time to review all of this yet. So I think it's good to point out that the purpose of those samples are just to give you an idea of envisaging how it might look to have that many pieces of data in a document. Aesthetically, I've tried to make them very agnostic to any kind of EPR system, and they look very plain. And really, any kind of design decisions, obviously we're thinking about how and what should be, what we recommend should be populating in a document like this. But how it looks is really going to come down to two main factors. One is the EPRs that your organisations are using. That will impact what kind of documents you can generate, how they look. But the other thing to consider is working, and I think this is a really important thing to say. A lot of you will be familiar with, for example, the work of discharge passports across London. Now, they tend to be specific to an ICS, and in the case of discharge passports, a lot of digitisation work that's happening. We'll find organisations grouping together to discuss the look and feel of the discharge passport for that ICS. And so one thing we would say is that if you think that this is something you'd like to undertake in your area, sort of moving forward and implementing recommendations like this, working with other members of your ICS is really important. And the considerations or principles or decisions we've sort of said that we came to through the period of stakeholder conversation. Number one, the main digital foundation of this work is that you are helping your organisation move from manually populated documents, so like we say, documents populated outside of the EPR, like Word templates and referral documents that you might access online from a healthcare centre's website, onto EPR generated transfers of care. And some of you may already have taken that step. The second thing is trying to make more progress toward capturing nutrition related diagnoses and findings. I've given the NDD as an example. I appreciate that's not taken up, that's probably the better word. It's not taken up in all areas, and that actually doesn't matter. It might actually be that your diagnosis is captured in the problem and diagnoses part of a patient record, but really that idea that we talked about in the beginning about capturing some of that structured and coded clinical language within your documentation, which is impossible to do if you're putting documentation straight into a Word template. And the last thing is that through the stakeholder process, and this was something that was really surprising to me and important for me to understand as someone who hasn't worked in community care, it became apparent that community teams were telling us that they often lack shared care agreements with primary care. So actually a lot of clinical and non-clinical information that we might assume in acute settings is viewable by our community care colleagues isn't always the case, and they rely a lot on some of that documentation. And this is where, again, taking an ICS approach so that you can understand what type of information may be useful to include because of those centres not having access to certain parts of a patient record, that's a really important argument for making those decisions together. Now, just speaking to a little bit about the digital data set, and we have got a lot of information in the published documents that explains what certain things mean, but just wanted to speak to a couple of those bits today. So I'll just show you here, this is an example, just a snapshot from the data set. Information in blue, which is, as I say, sort of stipulated or outlined in the recommendations themselves. Information in blue are the pieces of data that have already been mandated by the National Transfer of Care sort of initiative, or within the standards rather, that fulfil that initiative. So, for example, inpatient discharge summaries, outpatient attendance letters, clinic letters, they already mandate that these are the kinds of things in them. You'll know that within your organisations, you may be in various stages of maturity towards adhering to those processes already. Some organisations are really far ahead and some aren't. So just to sort of, I suppose, reiterate and be really transparent about what this particular data set is, this is a recommended digital data set. So this data set in its entirety isn't mandated. We don't have the authority to mandate this data set as a whole, but I think it's really important for everyone to understand what pieces of data are already mandated, as this is a piece of data that we expect to see when for example, a consultant writes to a GP, or there are also similar sets for when a GP makes a referral to a consultant-led service, for example. And I think that's really important that we're clear about that. Items in blue, and you can see a couple of examples here on this page, are not parts of that digital, so that mandated data set. But these are the things that we've arrived to as a stakeholder group. And as I say, we managed to have a lot of input from a lot of different parts of the patient pathway. And they were discussed a lot during the stakeholder meetings with some really interesting outcomes. So I'll draw your attention to first the nutrition screening tool score. So we had a really interesting discussion around the prescribing support dietitians, and how a high must score, as an example of a screening tool, a high must score generated in an acute setting may be significantly impacted or contributed to by a acute illness score, that part of the tool. And actually on discharge, the patient's risk of ongoing malnutrition may be quite different based on the fact that that part of this score is no longer relevant. So a rescoring of that patient would arrive to a different screening risk score. And for that reason, there was a lot of emphasis from our primary care colleagues and community colleagues to sort of say it would be important to include the pieces of data, each score that contribute to an overall screening tool score, and not just the score. Now, if we weren't talking about digital transformation right now, so if we were saying, okay, everyone, we want you to start capturing all of those pieces of data when you fill in this Word document that you're going to send to us to refer your patient, I think we'd have to be really pragmatic about how onerous that would be, although it, of course, would improve the quality of the information. But it's just to remind us that what we're saying here is that although we're asking for more information, we're recommending more information is shared, and that's around improving the quality of the information that goes across. We are promoting and endorsing that that be done using the sort of automated processes that do exist in electronic records. So drawing those pieces of information from the structured fields where they live. We're certainly not asking everyone to start typing those things into boxes. And then the second example that I have is something around, and this was a really interesting topic that came up through the conversations as well. So there were a lot of views around how we evidence that the threshold for criteria for prescribing ONS is met. And I'm just going to use this as an example just to try to give something a little practical around this kind of thing. So let's say you have the ACBS criteria. You're pretty familiar with this list. I imagine that this will evolve in time. I know this isn't the only part of considering a recommendation for ONS. There are two approaches that you could make if you wanted to digitise how this goes. And some of you may have already taken this approach in your local organisation. So one of them is that you could build something that functions like an auto text or a template, where you can build this as a list that selects. And if you imagine that this was a drop-down menu on your screen, that you click the appropriate criteria for prescription, that fulfills the the element of communicating more clearly, if you're not already, an ACBS criteria for prescription. So it communicates it clearly and you're using structured terms. But data in a document like that into a template or a sort of an auto text is actually really difficult to analyze. And so to take that one step further in terms of a digital optimization, it would be to build that field into part of your EPR system, whereby you use the same approach. It could be a drop-down menu where you then can enable a structured response, but it is built solidly into the EPR record. And with that, you can then analyze, for example, I would like to know of the 500 or 1,000 patients that we sent off referrals to community, how many of them, or referrals to the GP, requests for ONS, how many of them did we say that we needed that because they were suffering with dysphagia? for example. So sort of building it into an EPR allows that greater depth of a greater depth of understanding about your service. And the last thing on this topic is just thinking about desired goals and outcomes, because this was another really topical thing that came up during the stakeholder process. Now, what we arrived to, the decision we arrived to, was really to keep this part of it as free text, but again, drawing ideally from your EPR entry. So, if you've seen a patient, you've set some goals, drawing that information from a consultation into the letter or the transfer of care. Now, this is a really debatable one, because you could argue that patient-centered treatment means that the evidence is going to be the goal is going to be quite specific to an individual, and we want to capture that nuance, and that's part of what makes us dietitians, is that level of expertise. But I think there could be an argument to be made for also capturing in some structured way the theme of that outcome. So, for example, is it to address undernutrition, address overnutrition, impact the symptom burden? It's sort of coupling a narrative or an individualized sort of patient-centered treatment goal with a themed structured capture, like checkbox. Let's say the patient's goal was to avoid losing any further weight throughout their chemotherapy treatment program in the next 6 months, and that's sort of been made specific to the patient because it's around their treatment and the time duration. And then the checkpoint would be, and this is a goal related to reducing the risk of malnutrition developing. Talking off the cuff, obviously you'd sort of have that outlined a lot more clearly than what I'm sort of saying right now. But this is, I suppose, just some examples that we wanted to pick up on today, because they were really topical during the process of consultation. So will this approach, we're talking about all of these pieces of data, is this approach going to save us time? Because it does, if you have made yourself familiar with the documents, there are a number of pieces of data that we're recommending are included in a transfer of care. Just to provide some reassurance, over half of those pieces of data should be able to be built to automatically populate from fields that already exist commonly within an electronic patient record. A further quarter of those, and when you read the sort of data set, we indicate where we suggest it could be configured to be a yes, no option, a drop down, or an automatic signature, for example. And then the last portion are those that require that sort of greater depth, nutrition skills and knowledge. And it might be that you've written that information, such as some of the goal setting information or other sort of determinations around assessing your past statements and things like that, and that you can then draw that into your transfer of care document from where you have inputted that into your electronic patient record. So really the idea here is this isn't useful to people unless we are automating and sort of taking advantage of the digital transformation opportunity that's there. If that's not there, then it really isn't a useful initiative. And then before I hand over to Rebecca, I've got a couple more slides, which is just to reassure people that we have been communicating with the BDA throughout this process. They couldn't join today, but I have shared sort of something for us to share with you today. The main thing to know is that this will be housed alongside of some of the other digital resources that they've got in their toolkit, and they sort of complement one another, really. The work of the BDA, which is focused around the building of the patient record itself, the dietetic record in EPR, and then this is focused on that part of the pathway where patients are transferred between care settings. And finally, just a little note about how you might go about implementing something like this. So I've already referred to the fact that we don't have the same starting points. None of us will have the same starting points for this project. And it's really important to acknowledge that. So some of you may already think, oh, we are already generating both GP letters and other letters from our EPR already, but we are still manually populating into a document our transfer of care when we want to send someone over to community practice. And so it might be that then is your focus. For others, you might have already moved over to an EPR generated transfer of care, but you haven't optimized that to sort of produce the greatest efficiency. And I think that there's a few approaches, but one of the things that really came out of the conversations we had with stakeholders was probably that working as an ICS is going to be a key to success if you want to genuinely make improvements, and also working with your local digitisation teams, whether that be at an ICS or organisation level, and to be honest, it'll be both, to help incrementally make some of these improvements that we would expect to be able to see if you embed some of these changes or all of these changes. So I'll hand over to Rebecca now, who's going to talk a little bit about measurement plans and sort of monitoring of how this process works.
Yeah, absolutely. So we have been thinking about measurement right from the get-go, and I'd like to thank Barnet Hospital and Barnet Community QI support for giving us some of their time. I've got a lovely definition here from the Health Foundation about quality improvement, and that's how we would think about measuring this work. And I think one of the really nice things about this project is that the people at the coalface, so a lot of you on this call, that are really close to the issues, have been really at the forefront of driving this work. And so really just thinking about whether we can use a coordinated approach to solving these challenges using the sort of methods and tools that we've been talking about. Next slide, please. So if we look for the model for improvement, we know that we are trying to accomplish something important, that our aim is improving the efficiency and quality of nutrition transfers. And we know that the idea that we're sort of testing is the recommended digital data set and building that process automation into the EPR systems to make this easier for people. Next slide, please. But how are we going to get data? How are we going to measure this? And I think this is really, really key to this project. So the first and foremost thing is we have designed some surveys, qualitative surveys for pre-implementation. And that is, there's a slightly different version for those that are initiating the transfer of care versus those that are receiving a transfer of care. But it's a really lightning quick survey to fill in, just about your experience, really. And then once you've got it built into your EPR and perhaps incorporated some of the changes that we're talking about today for your organisation, and the system is bedded in, there'll be a second set of surveys, which is basically from the similar questions, but now that we've improved the process, we hope. To again get the feeling of people on the ground about how this is improved or not, their use of time. Because one of the key questions we're asking about is this a good use of dietetic time? One of the common frustrations is around sort of filling in Word documents, but actually way we're doing this with the sort of 23% that really need your dietetic degree or your dietetic skills to be able to complete the really specific nutrition transfer of care information. And of course, we're thinking about some balancing measures because that's been quite a challenge for this project. So we're thinking about number of referrals overall. What if it goes up? What if it goes down? We don't have control over those things, and there can be many external influences, but we will be measuring those. And the numbers of nutrition transfers of care sent and received is easier to measure. Prescribing of ONS potentially from the hospital side would be much easier to measure, which of those have an NTOC attached to it. And so if we go to the next slide, please. If we just look at some community data, referrals from a certain hospital, we've already started collecting run charts, just the standard data around number of referrals received. And I know that teams already collect information about sort of appropriateness of referral and so on, and can really be sort of thinking about how this does improve the ease of triage and everything. So those are some of the measurements that we're planning as part of our evaluation for this work. Next slide, please. So we know that this is quite a lot of information on to take in one webinar. So we are thinking about more detailed discussions and potential for implementation guidance, or at very least checklists, and further work in the new year. Don't know if you want to add anything, Sinead.
Yeah, I think that's, I mean, I expect it'll probably come up a bit in the Q&A that we'll embark upon now, because I think that implementation has been one of the themes, hasn't it, during the stakeholder conversations around some people feel really confident and, you know, positive about how they might wish to implement something like this, sort of a digital improvement. Others feel concerned. And I think that's one of the reasons that we incorporated a Q&A section into today. But I think it's to say we're not disappearing. We're hoping to, as I say, work with the BDA, for example, to help nurture a process like this along for those organisations that wish to adopt an approach like this of sort of digitised transfers of care.
Absolutely. So if we move to our next slide. What we're hoping to do is reflect a bit on the challenges or concerns and celebrating what we've achieved to date, because I think it is worth sort of taking stock today that it's so far been a big piece of work. It's been done by collaboration, people coming together and finding time in busy jobs to sort of work together and problem solve. So on our panel, we've got Steve Tolan, Rebecca, who I've introduced previously. We've got Rebecca Youngman, who's clinical lead dietitian at Whittington Health in the acute side. We've got Hannah Style, professional development lead for East London Foundation Trust, so representation from mental health. We've got Vicky Malone, medicines optimization lead dietitian for South West London. Vittoria Romano, specialist nutrition support dietitian for community CLCH. And we've also got those of us that are on the steering group, so myself, Sinead, Jane, and Maria, also, and Vittoria, also here to sort of support. So if we go to the next slide, please. What I'd really like to start off by asking, as sort of beginning to get us going, is from a sort of acute or you know, different perspective, what do you see the impact of this work being? So if I go to you first, please, Rebecca.
Yes, thank you. I think for us working in an acute setting, last month I did a quick data collection. It wasn't that easy to do because we do put all the information into a Word document and then send it out to our community colleagues. I think this will enable us, if we build it into our electronic patient records as an actual template, that we will then be able to track if the referral has gone. And obviously it will reduce the amount of typing in that we do or we ask our administrator to do. Another challenge that we've had in acute recently was with a referral that somehow got lost and didn't get sent on, even though it had been requested to be done so by our administrator. And I think this kind of puts the emphasis back on you as the healthcare professional, making sure that you have done that health professional to health professional handover, and it makes it a lot easier to do it because obviously we'll just be drawing the information from our electronic patient notes. We're already, I would say, a little bit along because we have our own clinical notes. We're able to adjust them relatively easily. We're quite a small hospital. Our IT support staff are very responsive. And I'm looking, for me, as well as hopefully taking this on as a transfer of care project, to also start building in the outcomes to be able to get some data as well from, you know, just the whole. I'm not really a digital champion, but this has enabled me to maybe lead forward and do some other things that we need to do around nutrition as well as transfer of care.
Thanks, Rebecca. I wonder if you want to answer the same question, please, Vicky.
Yeah, no problem. So I guess in my role as a medicines optimization dietitian, I am hoping that a big impact of this will be increased adherence to our ONS prescribing guidance. So we have our prescribing guidelines which set out criteria that patients should meet to enable them to sort of qualify for an ONS prescription. And we're doing lots of training and education with our GP practices to help ensure that they're following this guidance. But to enable them to follow it, they need certain information, which obviously it would be really helpful if we can be confident that it's coming in dietitian letters every time. And at the moment, loads of our letters are really, really good, but there are some situations where we're lacking a bit of information. And also sometimes the way that the letters are formatted and set out, it can be a bit difficult for GP practice to actually pick out the relevant information. So I think it's kind of two things of A, having all the correct information there, and B, sort of standardizing the format and making it really clear and easy to read. So I think those things will be really, really helpful for GP practices. And again, as we're sort of promoting our guidance more and more, we're finding that GP practices are questioning when they get a prescription request from a dietitian and it is lacking some information. They are then going back to the dietitian to request information to fill in the gaps, which obviously all takes up time. So yeah, I'm hoping it's going to make it much easier and yeah, free up time for GP practices, which is obviously really important. Also, so I think Sinead or Rebecca touched on this earlier. We in Southwest London, where I work, we do have a bit of disparity with community dietetic services. There's a couple of boroughs in particular which don't have much of a service. So when a patient is discharged from secondary care, we are very much expecting the GP to carry on the nutritional care of that patient. And I think we're finding that GPs, pharmacists, or other staff in GP practices don't always have the knowledge or the confidence to be able to do that very well. So again, any information that we can give to help them to support with the nutrition, with the continuation of the nutritional care, with reviewing ONS prescriptions, I think that's all going to be really helpful for patient care as well. And if we can get increased adherence to our guidelines, it's going to be hopefully the knock-on effect of reduced waste, reduced costs, all beneficial for the NHS.
Absolutely. Victoria and Hannah, I don't know if you, Victoria, if I come to you first, if you'd like to speak to this.
Yeah, I would echo what Vicky said in terms of oral nutritional supplement prescribing. Within one of the London boroughs that my team covers, PCN pharmacists did an audit and identified that 50% of the high ONS spend was dietitian initiated, and the lack of information made it very difficult for them to be able to manage that prescription. So they're screaming out for, if you give us the information, we're happy to kind of manage it, but we need that information, that detailed information, to be able to do this work. I think from a community perspective, we're spending a lot of time triaging, as I know our acute counterparts are spending a lot of time writing the referrals. And so what we're hoping, we are declining quite a lot of referrals. That's not just dietetics, that's GP as well. So anything that improves the quality of the information, that means that there's no delays to a patient receiving the treatment or care that they need, I think will be really valuable with this piece of work.
Excellent. And then Hannah, same question.
No, yeah, I think it will be really beneficial in mental health settings where dietetics is hugely underrepresented. I think it will be really great to have this pro forma that's consistent and gets us on the map, and really raises the profile of malnutrition being an issue in mental health settings, which is largely overlooked and invisible at the moment. So I think just having some standard that we all need to stick to will really help to bring the visibility of mental illness and dietetics.
Yeah, I couldn't agree with you more.
I can see we've got a couple of questions now in the Q&A as well.
Yeah,
the first one's a doozy. Can you see that one there? I don't know if everyone can see the questions or not, actually.
I think they can. So I think Erin's asking us about the GLIM versus different risk scores for nutrition and how it's been diagnosed. I think for ACBS, where the nutrition diagnosis doesn't entirely match with the ACBS criteria. So we're going to have to work through that, and obviously there would be scope in future for refining that if that's the direction of travel. But I think for the time being, we'd have to use disease-related malnutrition, recognising that it's a bit of a catch-all. And hopefully, I think Alison is on this call and wouldn't tell me off for saying the wrong thing. But hopefully, I think it will be perfectly workable basically what we're doing already. Alison, I can see you've got your hand up, and I don't know if we can actually let you talk, because we've got.
I think we might be able to let her actually.
Lovely.
Let me just allow mic and allow
just
camera.
Whilst you sort that out, okay.
There we go. She's all good.
Thank you. Thank you. Yeah, I saw that question from Erin and thought I can answer this. Risk of malnutrition isn't an ACBS indicator for most ONS. I had a quick count up while everyone was speaking. There are 9 ONS out of 74 where risk of malnutrition is actually an indication. The problem we have with ACBS indications is they are not consistent, they are historical. Goodness only knows why they were set. And they are different for lots of different products. So even where you've got products that are basically the same thing, there will be different criteria. It's mad, it's not helpful, and there is a plan within ACBS for us to sort this out. But the thing to remember always, I'm afraid, is it isn't ACBS who sets the criteria, it's the manufacturers. And at the moment, we have to go back to the manufacturers once we can come up with alternative criteria and get agreement from the manufacturers to go for alternative criteria. I would like something to be very simple, very straightforward, but we are hemmed in by history, basically.
Okay, thank you, Alison. So moving on to Gemma's question, who's asking about how long the process takes. I'm not quite sure what you mean there, Gemma, sorry. The idea, people have been doing this as part of their day jobs, and we've launched a ticket, the Royal Free, to get this built into EPR, which it wouldn't necessarily be an additional role or anything, and that people would still be doing their clinical jobs alongside sort of embedding some of this stuff, is how we picture it. So I don't know if that answers your question or if you want to clarify a wee bit. In the meantime, I had a question for Steve, and I don't think there's any other questions on the chat, about if you think this model could be used for other AHP groups looking to improve transfers of care.
Well, so I think the starting point within this, it kind of links to the first question. So for this to be successful, it needs to be hitting across productivity, and I think give an example of where it would, around avoidance of harm, so where people are being given the wrong things, in reduction of cost, and there's a particular big cost associated with some of the challenges ONS and transfers of care that may not be so applicable for other AHP groups. So safety, harm, quality, patient experience. So Rebecca, I think you gave an example about people being very delayed or not necessarily getting what they need to. So I think what's relatively unique in this is the cost opportunity and the productivity elements. And I think where other professional groups can identify similar opportunities in that sense, that's what's going to be beneficial. But I think for this to stick, for this to have priority for IT teams and various other clinical and commissioning stakeholders, those things that we know to be true need to be evidenced in order to do it. Now, what's really great is several of you have already said that ICSs and other teams know some measurable problems linked to current practice that is already your baseline. So in those contexts, it's actually being able to just demonstrate an improvement versus that, which this could do. And the key principle is this needs to not feel like red tape. This needs to be an enabler, which I think it will be, but it's evidencing that as you go along.
Yeah, I think seeing things as red tape is a real good way, useful way of sort of picturing it, and certainly thank you for steering us towards that NHS England and work on that. I think that's certainly something we can look into. I haven't noticed any other questions in the chat, so I don't know if any of the other fellow panelists want to step in with a last cheeky comment or question. Rebecca.
Yeah, just really going back to Gemma's question, if it was around what I was describing, asking our IT team to help us with creating a special note on our electronic system, actually it doesn't take that long, because I think you've provided us with all the information that's needed. So really the work is actually done by your IT team. So it's asking them to do it rather than you as a clinician. I mean, certainly our team come back to us, they say, oh, could you have a quick look at this? We talk it through, we try it out. If there's one or two things, they literally change it when they're in front of me for our system, and then we trial it, and then it can be adjusted if something doesn't work later down the line. But actually, I think it's your IT team that you need to get on board and sell it to, rather than the dietitian doing much of the work. That's been our experience anyway.
Thank you. And Hannah, did you want to say something as an extra, or will you not change your mind on that?
I'm aware we're at time, don't worry.
So as a sort of summing up comment, I would say that there aren't that many EPR systems. So as we start getting it built at one place, I think there is definitely an opportunity for spread across different EPR providers and suppliers. So that would be certainly something that would be useful to look into as the next iteration. So on that note, we're just a minute over our cut-off time. So I would really like to say a huge thank you to the panelists, the Short Life Working Group, the steering group, to Steve, and to all of you that have contributed to this work so far. We really, really could not have done it without you. It's been magnificent effort so far. Do get in touch with us, but we will be following up in the new year with some more thoughts on implementation. So big thank you to all.
Thank you.